Good morning, everyone. Thank you, Neil, for this introduction. I think you have not told the whole story. The reason why I am the director of IARC and why I'm here today is because of Neil. Because Neil came as a teacher to Pelotas, Rio Grande do Sul in 1994, I think it was September. And 2 months after my encounter with Neil, I went to IARC to do the practical part of my thesis. And here I am, a few years back. So I have not had the pleasure to be as a student here, but I am indeed a student of Neil. So Neil, thank you. Thank you for all you have done. And thank you for me being here today. So Neil asked me to talk a little bit to you about the global transition and the ways forward in cancer prevention and how cancer epidemiology has combined all the knowledge that has been developed basically for 1 century to what we are doing today in cancer prevention. So it's a little bit challenging, but I'm going to try to take the challenge. So I'm going to talk briefly about the epidemiological transition, but also about the methodological transition in epidemiology, the potential for prevention, and the ways that IARC is doing, things that IARC are doing to contribute to the global level, and also talk a little bit about perspectives for the future. So first of all, and I believe you might have been discussing this during the previous weeks, the globalization in health. There is a very rapid changing scenario in terms of disease burden globally. It might be a little bit difficult to see from the back, but I will make my slides available. So basically, we see dramatic changes in all-cause mortality, but also in dengue, with very high increases in some areas of the world, a dramatic decrease in diarrheal diseases, forces of nature, back and forth, up and down, heat and cold mortality rates varying dramatically over the years, malaria, dramatic drop in malaria, in particularly in Africa, rise in some cancer types, such as malignant melanoma, in many countries of the world, and decrease in protein and energy malnutrition. So rapid changing scenario of disease worldwide. And I think you have discussed this definition in depth, so I'm not going to go through it. But the bottom line is why you are here today is to provide tools for prevention, for disease prevention globally. That's your ultimate mission from all of us in this room. And also for the ones among us that work in cancer epidemiology. So that's the ultimate goal. We do a lot of different kinds of methodological research, etiological research, but our goal is to prevent disease to occur, and if it occurs, to prevent people of dying from it or dying of it as late as possible in the stage of diseases. So public health in the last century has really saved hundreds of millions of lives through implementation of prevention strategy. And I list here some of the most successful ones. Accident prevention, vaccinations, and you have discussed this thoroughly today and the challenges with it, safe drinking water, tobacco, occupation, and nutrition. And basically everything we know about these measures has been discovered and partially implemented in public health using epidemiological methods. I just give one very clear example here, which is the mortality related to use of vehicle miles, to use of motorized vehicles. So this is the curve of deaths in the US for road accidents, and this is the number of miles. So the graph is like this, right? You are step increase in the numbers of miles, but a dramatic decrease in mortality. Why? Prevention, right? Implementing very simple, apparently simple prevention strategies to decrease mortality. So prevention works. This is an example, very simple example, but it goes far beyond this. So mortality rates decrease when prevention is implemented. There is plenty of evidence for it. To implement prevention measures, we need to understand the etiology. And we are not here today publishing our papers and saying, okay, I'm contributing to this and that. It's an enormous amount of evidence accumulated throughout the years. And our contribution is really a small step standing in the shoulders of giants, people that came before us and really paved the way from all what we know in terms of cancer etiology for prevention. The first interesting and relevant epidemiological studies are, amongst others, for occupational agents. And there are some landmark findings that really defined epidemiology in a way. The findings from Ramazzini on breast cancer among nuns, scrotal cancer among children cleaning chimneys, exposure to sunlight resulting in skin cancer among people working in boats, for example, osteosarcomas in workers exposed to radium, and lung cancer, of course, among minors. So this started already in the 1970, 11 until the 60s. So there was a sort of golden period of discoveries for the first time of exogenous agents that would cause cancer. So from the 50s to the 80s, there was an explosion in the methodology for this, for occupational cancer. And then it came a period from about the 40s until now where lifestyle risk factors were described in detail. And we based a lot of what we do today in these studies. For example, the studies on lung cancer by Doan Pito, ovarian cancer and oral contraceptives use, a very dramatic decrease in risk of ovarian cancer, and solar exposure and skin cancer. So these are very recently, historically speaking. And the golden period for these etiological studies in sort of lifestyle risk factors was between late 70s and in mid 2000. So a little bit later on, many groundbreaking studies on viruses were produced. And one example that I will use throughout the lecture is the example on HPV vaccines, which many of you, in particular the people in the Nordic countries, now have been seeing the implementation in the last decade or so. Very recently, in the last 2 decades or so, we see an explosion of new methods in cancer etiology discovery, which related to biomarkers, basically genetic epidemiology and the exposome, which I'm going to discuss a little bit later in this lecture as well. So cancer is a disease as any other disease in transition. And here I'm giving the example from Japan. So for how was it before, just a few decades before, and how is it now? From the epidemiological transition, Japan went having as the most important disease malaria, tuberculosis, smallpox, to this area that we are now after, the area of non-infectious disease being the most relevant ones, where cancer, heart disease, and stroke are the big killers. In the cancer transition, we also, when we specifically look at cancer, we see a dramatic change in the types of cancer that occur from a few decades ago to now. For example, a few decades ago, the predominant cancer were stomach, which is caused by Helicobacter pylori, cervical cancer, but caused by HPV, and liver cancer, caused by hepatitis B and C viruses. And now, more recently, we see a totally different pattern, which is lung, pancreas, associated with smoking, colorectal cancer, associated with the westernization of diet, and breast, related partially to diet and to reproductive patterns. Very, very large change. And maybe you have also discussed a little bit migrant studies, and migrant studies is where we can see this transition in an extremely clear way. Here again, I take the example of Japan and people born in Osaka, in Japan itself, and migrants to Hawaii of Japanese origin. So just looking at the stomach cancer example, in red is people in Osaka, the cancer rates of stomach cancer in 70 and 71, and 80 to 82 in purple. And then in those of migrants, Japanese migrants to Hawaii, a dramatic decrease, evidencing very clearly the impact of the environment in cancer types. And this you see basically, you observe the same phenomena for many other cancer types. For prostate cancer, very low in Japan, and after a few decades of migration, an enormous increase in risk. Colorectal cancer, same thing, and breast cancer, tremendous increase with migration, and then the Japanese reaching levels which are comparable to Caucasians. So going further, how do we explain this? And this maybe you have also been discussing early on, is a lot done to the transition in lifestyle, which is best reflected by the epidemic of obesity. So the obesity is currently, I would say, one of the biggest challenges of public health globally. So there is no evidence that the epidemic of obesity is halting, basically in any country in the world. We see a very dramatic increase in obesity rates. And here there is a list of different regions of the world and the total number of inhabitants with BMI over 30. A very dramatic increase. So this epidemic is truly out of control, and not only for cancer, but for other diseases. It's very important that we pay attention to it. And just to make a point about the example, I'm showing here the mean BMI in 80 and 2008 for women and men in different countries. And you can see the dramatic increase on the prevalence of the mean BMI increasing really systematically and substantially in a tremendous way in some key countries. And again, this is observed throughout the world in all age groups, and is more accentuated in women than in men, with dramatic consequences for health. Continuing the epidemiological transition, we could think, well, what is happening? For example, tobacco. We have known that tobacco is a carcinogen for the next at least 60 years. So have we done enough to prevent it? And what are the effects? And indeed, we start to see some effects of the control or the attempts to control tobacco smoking, both in low and middle income countries and in high income countries. And these are the lung cancer trends in men, where you can see that many countries, both in low and high income countries, show a decreasing rate. So it's very slowly, the curves are decreasing. But in a few countries, such as the Philippines, is still on the increase among men. However, look at the picture among women, the other way around. It's going up. Why? Well, women start smoking a little bit later, right? It took a few decades for women to catch up the same smoking rates than men, but we are still observing increasing trends in smoking among women in most countries on Earth. So we are still going to face a very large lung cancer epidemic in the decades to come, and women will be very much affected. China will be a country where most of the deaths from lung cancer will be observed in the future. Again, regarding the epidemiological transition and how this affects different populations in different countries, but also within countries and within regions in a quite different way. And here I just show the impact of social inequalities in cancer. And basically, I list the European Union, where there is rather homogeneity in terms of socioeconomic status. The European Union citizens are the wealthiest in the world, basically. They have access to almost everything. But if you look at people with low socioeconomic status within the European Union and high socioeconomic status, you see quite clear gradients, difference in gradients in terms of cancer incidence and mortality. In this part of the graph is people with low education, men, and you see higher levels of cancer incidence throughout basically all cancer types and countries as compared to high education and status. And similar for women, higher cancer rates among the poor than among the wealthier. And this is, again, a phenomenon that we observe for almost all cancer types throughout the world, including your own countries. This is European Union comparison, but when we compare individual countries, we observe the same phenomena. How about the methodological transition in epidemiology? When I was trained, basically we used questionnaires, and sometimes we took blood samples and we did some very basic biochemistry analysis. For example, for diet, all what we did, we asked people using food frequency questionnaires, what have you eaten last week or last month, or what's your usual pattern of diet? And many people would not remember, as is displaying in this cartoon, how much yogurt you ate when you were 15 years old, where we have a very vague idea, very imprecise. Methods have evolved dramatically, and now, for example, methods using photographs that estimates the amount of food, the amount of calories, and even the nutrients are being implemented. So it's a dramatic change in terms of technology for epidemiological studies. And this will have an impact in the way we as epidemiologists conduct our studies in the future, for sure. Again, things get complicated over time, more complex, but also more interesting. And particularly in the last 10 years, we have really seen an explosion exponential increase in the types of technologies that we have been using and implementing in epidemiological studies, including genomics, epigenomics, transcriptomics, proteomics, metabolomics, microbiome, and exposomics that would include all of this. This also makes things quite complex. But how are these new technologies being incorporated in decision-making and in evaluation and regulation of toxic substances? We are still lagging quite a lot behind. So regulatory agencies are not yet even starting touching or very, very superficially touching all these new methodologies for their evaluation. So we are still currently using very basic methods in our evaluation systems to control carcinogenic substances overall, but this will for sure change in the nearest future. There is quite a hype about big data, artificial intelligence, and precision medicine, in particular in oncology. Right? People are very excited. Now we are discovering these new drugs and they will sort all our problems. Cancer will be cured very soon. We hope so, but we are still very far from that. So the big data framework assumes that big data, many different types of data from different technologies, a lot of detailed information from each person individually and as population will be available in infrastructures that will allow us to link data together and then to better understand the causes of cancer and how to prevent them. And this would be done then with the use of artificial intelligence, which is basically teaching machines to analyze and interpret the data for us. Again, this is the framework. In epidemiological research and in epidemiological cancer prevention, we are still in baby steps of this. And we are doing some advance, but we are still not there. Mainly because the big data is partially not there. And as I'm going to describe to you a little bit later on, there are still pockets of the world where we know nothing or very little. We have a very, very crude idea what even are the cancer patterns in some regions. All that said, we know a lot. We know a lot about cancer etiology, and we also know about cancer prevention. So much that I would postulate that 40% of all cancer types can be prevented overall today with the knowledge we already have, if we would be implementing it effectively. And here I displayed the cancer types that we know between 75 and 100% are preventable, 25 to 74, and less than 25. So let's start with the ones that we know a lot and we could prevent most of it. Cervical cancer, we can prevent almost 100% of them with HPV vaccination and screening. Lung cancer, about 90%. Oral cavity and lips, about 90% can be prevented with things we know how to prevent. Esophageal, 90%. Melanoma, 75%. Stomach, 75%. And still, a very large amount of the overall cancer burden and deaths are due to these cancer causes, in particular lung cancer. Again, we know how to prevent it. And we could prevent this today if we were more effective in implementing public health practice. Among the cancers that we know, 25 to 74% of the preventive fraction: colorectal, bladder, kidney, liver, endometrial, pancreas, and breast. Yes, we know how to prevent breast cancer. 25% can be effectively prevented. So it's a myth that breast cancer cannot be prevented. It can. Among the cancers that we know a little bit less, and we really need to understand better and figure out how to prevent this. So we can prevent, as per today, less than 25% is ovarian, leukemias, lymphomas, prostate, and brain. Prostate is a big, big challenge, a main cause of morbidity and mortality among men globally, and we really don't know much about how to prevent it. So the proportion we attributed here is 0, and this information is, of course, available in our website, and you can download and use it freely with all the complementary information about it. So we are slow in implementing cancer prevention, and here it's just a few examples. So let's look again on the basics, the cancer type that we know most about. Lung cancer incidence and trends. We have been seeing that it has been decreasing in some countries, and let's compare with the total numbers. So while incidence indeed is decreasing, the total number of cases is still increasing due to age of the population and the increase in the total number of people. So even if incidence rates in many countries are decreasing, we still will, for many decades, face the enormous burden of cancers occurring, and we are going to need to deal with them. Another example that, again, you might have been discussing during the last weeks is the comparison between the UK and Poland in terms of cancer incidence, in purple for the UK and in gray for Poland. So exactly the same curve that we observe in the UK, we observe in Poland, just with a few decades, decalage one from another. And the curves and the implementation of the different smoking control measures implemented in the UK, and again, with about 20 years difference in time in Poland. Well, the obvious conclusion, we are going to see the same trends probably in many countries, depending to the prevalence of the exposure to smoking and the speed that they implement smoking regulation efforts. Does it stop working? Oh no, there we go. So how cancer control initiatives have evolved over time, and when did we start and where are we now? Since the 50s, the first cancer registries were established in the Nordic countries, in Germany and the UK, where we started really understanding in depth the cancer epidemic. In 1971, Nixon had the National Cancer Act. And from there, the IARC, the organization, the International Agency for Research on Cancer, was created and continued to exist and started producing evidence on what are the substances, in particular the environmental substances that cause cancer, so that governments could act on them. So the first monograph was the monograph evaluating the carcinogenicity of some substances to cause human cancer, was published in 1972 and continued being published to now. Only in the 70s, actually, that there was also an attempt to systematically evaluate very important things, such as foods and nutrients in cancer etiology, and propose measures to control their impact. And very, very recently, only that policies are proposed to governments to take action. So the history of prevention in terms of other things besides smoking is relatively recent. The 5-a-day policy that many of you know, I mean, eat at least 5 portions of fruits and vegetables per day, is only a few decades old. So the Cigarette Act has a much longer history because we have understood the epidemic of lung cancer early on, and the ban of tobacco advertising has been progressively being implemented in many countries, but still, as per today, we are quite far from implemented globally. The framework of Tobacco Convention, again, only a few decades old. So we are extremely slow as public health community between discovering the causes of specific cancer, understanding how to prevent them, and implementing them in practice. Smoking restriction, one thing that we know works is smoking restriction, again, very, very recently implemented globally. Other measures, alcohol, for example, even less. So very few countries have implemented effective ways to control consumption of alcohol. So in an attempt to help governments to guide their policy, the World Health Organization made this summary of evidence of the best buys. That means actions that are very cost effective and affordable to prevent non-communicable diseases include cancer. And they try to summarize them in very clear ways to help governments to implement them. And their measure, what is cost effective, would be that it would cost less than 100 international dollars per disability adjusted life year lost. So that is what was considered by definition very effective. And the usual suspects reduce tobacco use in any form by mainly taxation, plain package, banning tobacco advertisement, banning smoking in public spaces, and warning about the harms of smoking and cessation programs. Similarly, reducing alcohol, increasing taxes, banning or restrict advertising, restriction in physical availability and times of selling, restriction drinking, driving, reinforcing the laws, and psychological intervention for people in risk of becoming abusers, promoting healthy diet and physical activity. So these are the best buys. This we know it works throughout the world and is cost effective. The implementation, again, is still very far from being accomplished. Specifically in terms of cancer, what was considered to be very cost effective was in particularly the primary prevention of cervical cancer by HPV vaccination, human papillomavirus vaccination. Also, breast cancer screening is recommended by mammogram, despite the controversy that has been going on in Europe in the last 10 years. The conclusion after a very careful review of the all literature is that it is cost effective to do mammography screening, but also provides surgery, chemotherapy, and radiation therapy using low-cost technologies for the entire population, as well as palliative care, end-of-life care. So these are the most cost-effective interventions in cancer. Again, for you to have a taste of how slowly we have been doing progress in implementing our activities. Only about 30% of the world population today are covered by surveillance on tobacco use. Only 18% of the world population is covered by smoke-free legislation effectively, and only 12% of the population benefits for a total ban of advertising on tobacco. It's very, very low. Let's move to BMI. We discussed that obesity and excessive body weight is a big challenge. And here I list just for a few countries the proportion, the population attributable fraction for all cancer causes due to very high BMI in recent years. And I separate in green color for women and in red color for men. In the US, for example, almost 10% of all cancer in females could be prevented if we would remove the excess body weight, in particularly obesity, from the field. Other countries are very challenging, and for example, in China, the obesity rates are increasing very rapidly, and it will be really very soon catching up with westernized countries. What are we doing about it? Basically nothing. Basically nothing. Very, very few countries have any serious attempt to curb the increasing obesity. Do we know what causes it? Actually, we do. There are sort of details of epidemiology which are still unclear, but we know 90% of it. It's consumption of foods high in sugars and saturated fats and the lack of physical activity, right? So let's move to infectious disease and cancer now using the example of HPV. Human papillomavirus research has over 100 years history now. And the first discoveries were in the beginning of the century, in 1907, and they are still ongoing. So we know that now we have over 500 types of HPV. It's a type of virus which is very, many subtypes of it. But landmark research were already done in the 80s, describing the specific subtypes of HPV which were highly carcinogenic. And this led to the development of vaccines in the early 2000s and the implementation of effective vaccinations in the population, boys and girls. We started with girls, but now also vaccination in boys is being done in many countries, in particular in the Nordic countries. Epidemiological research has also been extremely important in defining the number of doses. The clinical trials recommended 3 doses of the vaccines, but actually observational epidemiological data using the cohorts that in a way had failed to vaccinate with 3 doses, but had girls with only 2 doses or 1 dose, were used in an observational way to observe the immunogenicity of the vaccine. And the conclusion was that actually 3 and 2 doses, the curves of immunogenicity for 3 and 2 doses are almost identical. And for 1 dose, of course, the immunogenicity was much lower. And this was published really quite recently, and because of these studies, epidemiological studies, the recommendation for 3 to 2 doses was issued by the World Health Organization a couple of years back. So many countries now changing from 3 doses to 2 doses of HPV vaccine. The amount of money saved in vaccination programs is immense, and this is entirely due to the good use of epidemiological research and people analyzing it in proper ways. So the conclusion was the non-inferiority in immunogenicity of 2 doses compared to D doses and the changing recommendation for girls aged less than 15 years. We know the vaccine works. We know it saves lives. We know 100% of cervical cancer prevention can be prevented basically by vaccination. How fast are we implementing it? Very, very slowly. What's the proportion of women worldwide benefiting from the HPV vaccine? 8%. Is it a shame? Yes, it is. It is. The vaccine works. 8% of the girls globally are benefiting. High income, middle income, lower middle income, and low income country. The gray line are the total amount of women in different age groups. The purple and pink lines are the proportion of target women for vaccination, and the dark purple are the proportion of girls receiving the vaccine. What we see is that only in high-income countries there is a substantial proportion of targeted women being vaccinated. All over the world, including where the highest proportions of cervical cancer are occurring, women are not benefiting. So again, very urgent action in public health using some technology that we have available and we know how to do is missing. We discussed primary prevention. Let's discuss very briefly secondary cancer prevention. So, screening. Screening and early detection is what in cancer is regarded as secondary prevention. Screening activities are very important globally, in particular for 3 cancer types: breast, cervical, and colon. And early detection is also extremely important. So not only screen, but the people that screen positive need necessarily to be followed up for proper diagnosis and treatment. Screening is an extremely complex activity, and we need to keep this in mind when comparing the benefits of primary prevention, secondary prevention, and tertiary prevention. There is a dramatic increase in complexity for these different measures of prevention. So we need to have appropriate screening protocols that work for specific countries, regions, cities. They need to be tailor-made for their reality. An organizational structure needs to be in place. Capable people need to be there for implement it. Linkage between different services to make sure that the patient receives the proper care. Needs to be a political will and needs to be money to be able to implement it. Healthcare systems need to be strength to be able to cope with the amount of work of it. Quality assurance, absolutely essential. Screening programs without quality assurance do not work and are a waste of money, full stop. Health information systems to evaluate the information and see how is it working, can it be improving, where it's not working and what should be done. And effective communication strategies to make the population compliant. Very, very complex, so it's not trivial at all. Giving a vaccination in many ways is much simpler, right? Because a vaccination is one time in life, that's it. Screening is usually activities that you have to repeat many times throughout life. Benefits and harms. For the three main cancer types, breast, cervical, and colorectal, that screening is recommended. It's really a balance between the positive and negative effects. All tests, including all screening tests, have both positive and negative effects. And the balance between them has to be weighed against the prevalence of disease and the incidence of the disease in the population and the burden in the healthcare services. Do we know that screening works, and how do we know it, and how epidemiological methods have been absolutely fundamental in establishing this evidence? In this graph, I show two examples from the Russian Federation and from Latvia, where in red I show the cervical cancer incidence rates increasing quite dramatically with change of lifestyle during the last decades. And then when screening was implemented and the expected and now being observed reduction in mortality rates. So it's an exercise that epidemiology help governments to do to understand what is the potential benefit, how to implement and how to monitor programs. As everything in public health and in care, there is an inverse law problem. So the poorest countries are the countries where preventive measures, including screening, are the most difficult to implement and most costly. And the countries which are wealthy, which have a lot of resources, are where these measures are easier to implement and evaluate. And this graph really just displays this, how regular access to healthcare, levels of resource, cancer-associated disparities, and level of organization of the healthcare systems, how they need to interact and how much it impacts in the organization of screening services. So the organization that the International Agency for Research on Cancer, what is this organization exactly? And what are we doing to help to understand the epidemics, to control it, and to provide evidence for public health action in cancer? So this organization was created, as Neil mentioned, over 50 years ago by a group of visionary politicians, actually. Not public health persons, but politicians in Europe. And the idea was that nations could join forces to curb the global cancer problem. Rodolfo Saracchi, who has been a teacher in this course for over 30 years, was the creator of the course, wrote this book together with other colleagues, telling all the history of cancer and all the milestones in the discovery of cancer throughout the last decades. So it's a historical book and very interesting to see the history of epidemiology impacting cancer activities globally. So what we do there? We do many things. Basically, we describe cancer. We understand what is happening, or we try to understand what's happening in different parts of the world, and we make this information freely available to all in an understandable way. We do a lot of etiological research. We understand exactly the causes and the mechanisms of cancer. And we implement implementation of activities to prevent cancer, and we evaluate them. For example, with vaccinations and screening. We also have a production of a lot of information material and education material, several books, and I will just highlight a few ones, which is the World Cancer Report, which is published every few years, which gives highlights of what is new in terms of cancer research and cancer prevention globally. We also do the monographs, and I'm going to describe that, and the blue books or the pathology books. This is basically the Bible or the Quran of pathology globally. All pathologists in the world have this book on their desk, and they all use the book to classify tumors. And all what we know about the cancer registration, how to classify, how to call each cancer is basically defined by this program that we have at IARC. So, in terms of describing cancer, this is where we were last year, and these graphs are all you can do it yourself using our website. So men in women in 2018, and what is here, the reality is that 1 in 5 men worldwide will develop cancer during their lifetime. The proportion is much higher in rich countries, much higher in Europe and in the US, and lower in other regions. And in women, 1 in each 6 women will develop cancer through their lifetime. It's substantial. Mortality, 1 in 8 men worldwide will die of cancer, and 1 in each 11 women will die of cancer. This is evolving over time. So all this information about what is happening now, what has happened in the past, what will happen in the future in terms of projection is included in the program with the global burden of cancer in 2018, but we have, of course, for all years. And this is available in our website, where we have a part which is Cancer Today, Cancer Over Time, which is Cancer Trends, Cancer Tomorrow, which are projections, and cancer causes, which actually estimate population attributable fraction for different types of exposures and cancer types. So these tools are all interactive, and I will only show a few examples to you, and if you want to do it yourself for your country, for your region, please use the website. All the data is there for accessible. So this is an example of the type of maps that you can do. This shows the incidence, the most common cancer in women by different countries. And pink color is breast cancer, right? By far, the #1 cancer type globally in most countries, with exceptions to sub-Saharan Africa, where in orange is cervical cancer. So very important cancer in sub-Saharan Africa. And also here, Mongolia, liver cancer. So this gives you a comprehension of what are the priorities. If we are going to do something to decrease incidence of cancer, which are the key areas that we should globally pay a lot of attention. So you can also do this sort of graph with global incidence and global mortality, again for women, where we show breast, 24% of all cancers are breast cancers in women, lung 8%, colorectal 9%, cervical 6%, and thyroid 1%. When we look at mortality, breast 15%, lung 13%, colorectal 9%, cervical 7.5%, and so on. So these are interactive tools, and you can play around and do your own graphs. So mortality among women, incidence, not all breast cancers are fatal. Actually, most breast cancers are cured. But mortality shows a very different picture. And in blue is lung cancer. So lung cancer being still #1 killer in lots of areas around the world, including Scandinavia, North America, Australia, and breast cancer being #1 in other regions. But look at sub-Saharan Africa, cervical cancer, 100% preventable, and we know how to do it, right? So this is in a way a tragedy, and we need really to act fast on it. This is just to display another way to understand the cancer burden. And this is age-adjusted, disability-adjusted life years per 100,000 population for cervical cancer on the left and breast cancer on the right, and showing for years of life lost and years of life lived with disability by Human Development Index countries. So very high countries, development index, that means rich countries, and very poor countries, and showing that the burden for cervical cancer is tremendously concentrated in poor countries. For breast cancer, the years of life lost are different in a way. So it's more homogeneous across development index of different countries, but the years of life lived with disability, that means the survival after a breast cancer diagnosis, is much higher in rich countries. How about men? Which are the key problems for cancer in men? In green color is prostate cancer. It's a very common cancer in most parts of the world. And the blue color is lung cancer. So lung cancer is still #1 incident cancer, in particular in Russia, China, North Africa, and so on. In India is oral cancer. This color here is oral cancer, very different pattern. Again, lung cancer, #1 incident and killer, followed by liver cancer as killer, but in terms of incidence, prostate cancer. Mortality, overwhelmingly lung cancer in blue. So what kills the #1 killer in men globally? Lung cancer. So what's going to happen in the next 40 years? Basically a very high increase in total number of cancer cases. So the cancer epidemic is not under control. It is not. So, and this just to show again, according to level of the development, the poor countries and the rich countries, all countries across the world will see a rather dramatic increase in the overall number of cancer patients. So we will need to monitor and to propose actions. And the way to do really this is really making data available. So big data and the whole heap about artificial intelligence will not happen if we do not have very high cancer data to supply to artificial intelligence and other tools to understand what to do and how to do it. So investing in cancer registration globally is a high priority in my view, and it will help cancer control programs. So what IARC is doing in this sense is investing a lot in low and middle income countries, basically giving the tools to countries to boost their cancer registration system, training healthcare staff on the ground for cancer registration, and providing them tools for quality control of the data, and helping them to collaborate in a network to make their data available. Other areas of research that IARC does a lot is in etiological research, and I believe that many of you have been involved in a way or another with the EPIC study, with the European Prospective Investigation on Cancer in Nutrition, a very large European cohort with 10 countries involved, 23 centers, 500,000 people that have donated blood samples, but also answered to a very thorough questionnaire about 20 years ago. And this data is mined in many different ways, including now for all the omics technology and made available to the community globally. It's a very important study that has answered many questions related to public health and cancer prevention. Another problem that sooner or later, if you stay in public health, you will hear about is the IARC monographs for the identification of carcinogenic hazards to humans. And these are books that summarize the evidence on carcinogenicity, and many countries use this as a first step to evaluate risk and to define legislations. So the program evaluates hazards, but does not assess at this point thoroughly risk associated with exposure. Third answer to the question, does a substance A has the inherent capacity of causing cancer, yes or no? And risk is how much of the substance will cause cancer. And I think there are many examples that we can discuss, but the one obvious is smoking. Does smoking cause cancer? Yes. How much smoking you use to cause cancer, there is a dose-response curve, and that's in particular risk that defines that. So this is a very thorough evaluation process that it's very, very regulated, because the resolutions have really a tremendous impact in legislation. All the procedures, how to do the evaluations, are very detailed in your website, if any one of you is interested in looking at them. But just to have you a taste of the complexity, all data is evaluated. Is the evidence in humans, the evidence in experimental animals, and also the mechanistic evidence is combined together in a matrix to determine if a substance is or not carcinogen, causes hazard to humans. There is also a similar evaluation which is done for cancer prevention, and in particularly primary and secondary prevention, and these are the IARC handbooks for cancer prevention. And again, the methodology is very standardized because many countries base their decision-making process to implement or not a screening program, for example, on this evaluation. This is just to show you the evaluation on mammography screening that we have done for different age groups with different technologies, the risks and benefits, and finally, the recommendations for eventual further action. All the evaluation produced is put into context in terms of recommendation, which are developed together with governments and the scientific community. And this is an example of the European Code Against Cancer that was an initiative from the European Union to summarize the knowledge into practice and recommendation. And these are the 12 ways to reduce cancer risk which are now recommended for the European population, with very specific guidelines for individuals, families, how to prevent cancer. This is again in the first page of the IARC website, and is available for individuals and governments. It does not include, the code was not targeted for policymakers, but to individuals, because many people ask, what do I do? Okay, alcohol is carcinogenic, but how about cardiovascular disease? Behind each of these recommendations, there is all the literature and all the way it was evaluated. So it's a very, very important source of information. All of this sometimes lead to initiatives of global level. Just to finalize, because I see that Neil is getting nervous, and I will just cite one, which was launched actually in May last year in the World Health Assembly. The World Health Assembly is the most important decision-making forum in the world for ministers of health. Ministers of health of the whole world, 194 countries, get together for 1 week in Geneva and discuss challenges and what are they going to do globally. And they have decided to now tackle cervical cancer. And this is really the first time in history that cancer is put forward as a global, in a global way, and a resolution will be adopted. The proposal was launched last year, and the resolution will probably only be defined next year. And the resolution will be, we hope, but I'm pretty sure it will be accepted, to try to get rid of cervical cancer altogether by the end of the century. So maybe the children of our children will see a world without cervical cancer. And that's what we should strive for. So this graph shows really how fast we are advancing in cancer prevention with the current vaccination and screening strategies. So very slow projected decrease in cervical cancer cases per 100,000. What would happen if we would do intensive vaccination, and what would happen if we would intensify vaccination and the screening globally, and the projections when we would reach levels which are below 4 per 100,000. So it will be a global effort to reach this, to decrease. And the vision would be then a world without cervical cancer, with a specific goal to go below 4 cases of cervical cancer per 100,000 women a year. And the target would be to have 90% of girls fully vaccinated with HPV vaccine by age 15. Remember, as we are today more or less at 8%, so it scale up to 90% by 2030. Huge, huge challenge. To have 70% of all women is screened with HPV technology, which is better than pap smear, at 35 and 45 years, so at least twice lifetime, to scale up to 70%, and to have a 30% reduction in overall mortality. So it's very ambitious, but I think it's not impossible if the global community pull forces together. take-home message. So we are indeed experiencing a transition in epidemiology, in the epidemiology of disease globally, but also in the technology and the methodology, in the methodological ways we do cancer research. There is still gaps to translate the research into public health action in cancer prevention. Big data and artificial intelligence will allow collecting and analyzing large amounts of information that will transform how we approach cancer prevention. And only through global calls for action, as the call for eliminate cervical cancer, the cancer community may be able to target certain cancer types for which we already have technology. So thank you very much for your attention.